Okay, we're at the end. We've got about 15 to 20 minutes to talk about anything really. The concept about this is what did we learn and where to from here. There was, I think, could probably all agree, it was just another great opportunity to network. It's wonderful to be back. It's been a few years since COVID now, and it's a lovely thing to have on the calendar each year. We've had a lot of novel findings today. There's still a lot to be found in terms of falls research. We had some research updates. One of the things that stood out to me was something from Auntie Rose's talk, and that was nothing about us without us. So I thought that was just a classic line, and it would go well beyond any research involving Aboriginal people, but to all our studies, whether we be researchers or clinicians or whatever, this whole idea now of co-design and collaboration is now key. I think that was a great line. Another thing they said, I hope we all get pumped up and ready to go. So hopefully that's what we feel when we finish today, when we go back to our work. So what I'm going to do, I've got some general questions for the panel, but I don't think there was much time for questions at all throughout the day. So if anyone's got a burning question from the floor, or in fact through Slido, now's your chance. So any of the speakers, you really wanted to ask them something, go for it. Can't see anything. No questions? All right. Look, there is one. Right up the back. Thanks, Stephen. Yep. And anybody else, if you want to ask a question through Slido, I can see it down here. So at any point you're thinking of something, please pose it. Yes, please.
This is a general question for the entire panel. I was just wondering if anybody has to say something about the actual practical implementation of Otago Exercise program, and what would be the ideal outcome measures, subjective as well as objective, could be measured over time for significant improvement.
Everyone's beaten. So the question was, what is the component or the outcome measure?
The question was, what is the practical implementation of Otago Exercise program, and what's the success ratio? And when we talk about the success ratio, it's about, I'm asking, what practical outcome measures has been used?
Okay.
If anybody who wants to shed light on that.
Pretty much, I suppose you'd go back to the original papers. It's one of the most validated studies, interventions of all, the Otago. So there is a lot of evidence published, both the initial studies and, like Daina mentioned, systematic reviews and the like. There's also manuals that really which still I think are available through the New Zealand networks. And outcome measures were many that we've talked about today. There were measurements of, apart from falls of course, but measurements of mobility, strength and balance. And they did show dose responses. So they're the sorts of things. It's the classic sorts of risk factors that Daina showed. It is effective in improving strength and balance and mobility. So they're the things to look for, as well as falls.
I believe the falls result was better in the higher risk groups that received that.
They benefited most, yep. Yeah. So my question then for the panel is, we heard about risk factors today. We also heard from Roisin about scare tactics and how people don't want to be scared. They're kind of like different things. In some reasons, scare tactics are to try and make people aware that they might be at risk and own the problem and have some level of community awareness. Yet we want a positive message. So I wonder if the group could talk about this from the different perspectives of the community and maybe residential aged care and the hospital, about balancing those idea of positive message versus knowledge, which might come with a bit of scary information. So, anyone like to start?
Happy to. Yeah, it's always a juggling act, isn't it? Figuring out how we can promote the importance of the prevention initiatives, but also focusing on the issue itself that we're trying to address. I guess from an individual perspective, it's taking the lead of the patient or the client that we're speaking to bring them back to reality in terms of what they can do on their individual level to reduce their risk of having a fall. But for us on a population-wide level across the state, it's about acknowledging and in most cases using the word falls and falls prevention and stay on your feet, but also talking about the protective factors that sit alongside that. So we'll never finish a sentence without having both of the equations as part of it, because we don't want to, as you say, scare people into the stats and the scary side of things. But in some cases, the stats and that are helpful, but not for us in a community setting, that's for sure.
So as a clinician in the hospital, I think a lot of it is about curbing expectations that people have from their hospital visit. And I think more and more we understand that the hospital probably isn't the safest place for older people to be, but there is a perception in the community sometimes that the hospital is very safe. And we do try our best to make it safe, but when you're in an unfamiliar environment, obviously it's very dangerous. So, it's really about when that patient comes into hospital at the very beginning, setting those expectations, having a direct discussion with the patient, but also calling their family members if they have pre-existing cognitive impairment to say, these are all the things we're going to try and do to reduce the risk. Unfortunately, the risk is there, and we have to keep people getting up and walking or whatever the task might be, and just let them know that it could happen. But we're trying our best to reduce risk, and I find that's probably the most beneficial from a clinical perspective.
Yeah, I think from what we learnt from the comeback trial and the approach that the coaches took to really individualise the recommendations for people, it was really around making sure that we understood what their goals and what their context was. And I think the other really helpful component was having an action plan around how to address the specific barriers that they raised. And I think one other really important component was coaches often used a confidence scale. So when they set the goals with patient or participants, they would ask them, how confident are you at achieving those goals? And they would rework the goals if the confidence level was anything under a 7 out of 10 level of confidence. So I think that really, again, reflects that kind of social and relational understanding of the complex issues that a lot of these patients face. So.
And then a final point on the hospitals. In the work we've done speaking with patients and families about, their understanding of fall prevention in the hospital, what we generally find is if the person's had a fall, either at hospital or at home, it's on their radar, they're concerned about falling, so they need less of the, education around, well, you are at risk of falling, whereas those that haven't had a fall before, it's for them that it's often a surprise back to that. They think they're in a safe space now, like I've got lots of nurses around me, I'm with the doctors, I'm not going to fall. And they're the group that then need more of that education initially around, well, you are at risk of falling here, and this is what we can do about it, whereas the group that have already fallen less likely need that education about the risk, and not necessarily scare tactics at any point, but that group you can more jump into the management strategies. What are we going to do together?
Okay, thank you. A question, I guess it's a question from the floor. It's a little bit about the falls huddle. So would that be, how are the learning strategies discussed in the falls huddle shared with the rest of the team?
Well, I think like everything, the theme today can be tailored around what works for your wards. We've had some wards that after their falls huddles, depending on the mode they've used, for example, some of our wards have used the reset tool to kind of reflect on falls, and they kind of then write up without any identifying details the main points across those. With that, you sort of recall the emotions, success, what went well, evolve, what are we going to do from this, and what are we taking away, and they kind of write those points up and put them in the tea room as one way. Any monthly meetings, that's often another point where it's shared, but I know with shift work, there's never everyone at the same time, so it's coming up with ways. Some wards have found WhatsApp groups or Teams work, but again, there's variable engagement with those, so it's working out, I think, ways in your ward and speaking to your staff about, well, what would be a way that we could share this more broadly.
Thank you. This is one that again came from Rosin. The idea of move, improve and remove. So is that too simple? or is it too complex? Because even in move, improve and remove, you've got about 4 things under each category. This is just the problem of falls. It's just not a simple thing and with one intervention. So just open to the panel, is that about right? Or should we be having a simple, straightforward message, say about exercise? Or is this about the right balance? So just open for discussion.
I think it's a beautiful balance. I think from a delirium perspective, I was listening to your talk, I thought it was incredible how public-facing it is, how translatable it is, people understand what you're talking about. It is a really, really complex issue, but I think, breaking it down into those 3 really memorable categories is easier for everyone in our community to understand. So I think it's pitched just right.
I guess it's even worse than what it shows on the slide as well. So we're talking about improve your health, and there's 3 subsets that sit within that. We don't talk about delirium, we talk about cognition in general, we don't talk about incontinence, we don't talk about alcohol consumption. There's even more risk factors to unpack than what exists within move, improve, remove. But yeah, I think it is a good starting point, and hopefully a slip, slop, slap kind of message that's now seek and slide as well, that potentially over time might evolve to include more risk factors.
And I noticed that in the TV campaign, that video you showed us, you just looked at one element. So obviously you've chosen to minimise it, even distill it down just to that one element of your strategy or your health promotion campaign for certain advertisements. But I guess for some of the other questions here, Steve, about
you want to take one?
No, I'll ask it. What does the path to implementing that type of thing nationally look like? Is the government doing enough to support fall prevention given the current looming crisis we're facing with the ageing population? I think these are really interesting questions. What are we doing nationally? You're doing a great job over there. We're doing what we can here, but could we be doing more at a national level?
Yeah, I guess the answer is obviously yes. Encourage everyone to join the Alliance if you're not already, to try and build some of that national movement in falls prevention. I guess from the specific question around the implementation of the program on a national level, there is nothing stopping us from sharing the program as it stands now. So if you do have opportunities or you're interested in segmenting out part of the program, potentially you have resourcing to support some of the initiatives, the door's always open to enable that to happen. But in terms of a national rollout, it all comes down to money at the end of the day, doesn't it? So it's us continuously knocking on the right people's doors and getting that support for the national rollout in some form or another, whether that's just the mass media or the package as a collective.
Thank you. Any questions at this point? Yeah, a couple over here.
Hello, everyone. We see all the initiative and all the research and project today, and which everything is good. But my question is, as we all know, our aging population is increasing and the comorbidity of patient is getting higher and the acuity is high. Do you think the number of patients and nurse ratio is the main factor of all this increasing fall in our hospital and acute setting? And what is our government or national can do to prevent further falls?
Anyone?
That's a hard question. Well, I think always more can be done. That's what we're trying to do here. And certainly, I'll mention the Falls Alliance again. So that is really trying to lobby government to take more notice of falls. And there are indications at times that people are starting to take a bit more notice. Anecdotally, I think people are starting to see a little bit more awareness, and there's a little bit more media around falls these days, so that's a good sign. In terms of staffing and ratios, it's really tough. It's really tough out there. I'm not going to make any specific comments. It's beyond something I'm across enough, but other than that, I know people are working really hard under really tricky circumstances within tight constraints at times. And, it can be really hard to make a difference, but we do see examples all the times of people still making a difference despite those really tricky circumstances.
Thank you.
I might just add briefly as well that the New South Wales white paper on falls prevention has a really nice layout of strategies and recommendations as well for targeting falls prevention, and it lays it out in a really helpful way, targeting the many different levels. So, the individual level, some of the interventions we've seen today, at the organisational workforce level, and then also at that policy and kind of, to that point about trying to lobby to the government. And I think a key thing is also having that coordinated approach, because as we've seen today, it is very multidisciplinary and needs a lot of advocacy.
Can I just follow up with that? It's really good, like I said earlier, that we have lots of good initiative, but I think our workforce is drained, burned out to do all this work. I've been in nursing for 25 years, and I can see that there is really a struggle, and our generation, Z generation, it's really can't cope, honestly. So I think, I don't know, maybe it's another project for our government mainly, but I think it's on the ground, the frontliner is the one that really facing all this challenge. And the move of the nursing staff, it's really dramatic. That's just my opinion. I don't know for other facilities or hospitals have that experience as well.
One tiny comment I'll add that that the research is trying to do is always ensure two things like economic evaluation, so that when we go to government to lobby for these things, we've got the data to show the improvements and the cost savings, because that's what can help get really powerful impact. And sometimes it's sort of lack of moments of meeting people who in high places who can make big decisions. So if you've got the data there ready, that's going to give you the best chance, and that's what amazing researchers here are really working on ensuring they have, for when they have those magical moments of meeting.
Hi, I just wanted to sort of add to that, Mela's comment. I think, we've got an ageing population. We know that our hospitals are going to have to cope with a larger number. I think in a couple of years it's really going to peak with the baby boomers turning, I think at the peak year, they're all turning 80 this year, and in 5 years' time they would be 85. So, and I think with that, because medicine has got so good at keeping people alive longer, I think the big challenge that we're facing is the failing brain. And we know the impact of the failing brain and cognition, and we know that the strategies work really well when people can understand the risk and understand what we want them to do, but it's those ones that are very confused. And I get the impression that's the strain that our workforce has, that they haven't got eyes in the back of their head, whereas they had one confused person on the ward. Now they have no one that isn't confused on the ward. And I guess the other thing is it's not just aged care beds. I think we've all heard today that these patients are, I think it was Anita or this morning saying that the patients are all over the wards in 20 different wards, and surgical wards and cardiology wards. And so I think the real key here is that we need a dementia-capable workforce. We need to get into universities and improve the way that people can communicate with people with dementia and understand the behaviours, because it's the way of communicating. And I think maybe if we got better at that, we might be able to keep our wards a little bit safer. So, the dementia prevalence is going up as much as the old ageing population. So scary times, but I think that could be a big impact.
Anything to say, Anita?
I just say that, yes, our complexity of patients is objectively getting much more complex. You can just look at all our DRG data. It's escalating rapidly, and I agree with all of those comments just then, and I take my hat off to the nurses that are working in the middle of the night dealing with, patients that are, they're trying their best, but it is really, really hard in that scenario, and the whole ward is a very high falls risk, and as you said, they don't have eyes at the back of your head. So I think we're just using our data the best we can to at least go to our hospital executive and say, look at these code blacks, look at the rate of falls, we really need additional staffing. So I guess that's one way, is just to gather as much data as you have and take it and show that you might need additional staffing.
Okay, we're going to try and finish on time. For those who put in a question on Slido, if we don't get to ask it today, we'll make sure we can reply, and we'll put that on the website. The last thing I'd like to touch on is community awareness and engagement. And I was also interested in Rosen's issue where how do you engage with people via, for example, real people or cartoons. So I was wondering, just as a straw vote, and who thinks it's cartoons and who would think it would be real people? And I noticed you've changed from time to time and gone back from one to the other, but you're not beheld of it. Who prefers a cartoon? If you put your one for a cartoon, yeah, real people. So real people won that vote today. So I think that is the last issue. Any final points of wisdom about, furthering our engagement, trying to get people to take part, make them aware, own the issue, as well as work with people in this way. Any final comment? Daina.
I was just thinking that if you give people too many things to do, they won't do any of them. So maybe we should really be prioritising for individuals, but someone else might have something else to say.
I think I agree with what you said, and sometimes when we give our older population too many interventions in a multi-component program, it can get really confusing and onerous on them. And maybe we need to think of something else that could possibly combine everything in one solution to really bring across such interventions in a way that's acceptable and digestible for the bigger population. I'm not sure if digital health is something that could do everything, because we are still human beings in the end, and I think the kind of social connection that we look forward to sometimes is just equally important. And this is something that I can see that's being addressed in most interventions, and in my passionate book about concerns about falling, this is something that I didn't touch on, but I think we should also address that.
Okay, all right, I think that's about time to wrap up. Thank you everybody for coming along. And thank you for the panel. It was nice to get some feedback. If there's here we go. Up on the screen at the moment, there's the QR code. If anyone hasn't put in their final feedback, please do. Also, unless you really want to keep your name badge, we can recycle them so they don't go into landfill on your way out. The final thing, of course, though, is you will have noted this conference went incredibly well, again, smoothless, and we've got a particular person to thank for that. Of course, it's the quiet achiever up the back, Stephen Fu. Stand up, and thanks so much again. All went well, everybody was informed, the speakers all came. I think we had more than 50 speakers actually speaking today, so there's a lot of information, so lots to think about. Ideas, thoughts for new initiatives. So I think we'll leave it there. Thank you very much, and hope to see you again this time next year.